Dr. Young, everybody.
Thanks for letting me come and speak. It's really great to talk to people who deal.
Higher up.
Oh, sorry. How about that? It's really great to come and speak, and to especially the people who have to deal with TBI and its symptoms and all the changes that comes with that. Straight, face to face. And so I had hoped that this would not be so much a lecture as much as just sharing. There's a lot that's gone on in the last, just the last 5 or 6 years, as far as in the general scientific community, as far as how things work and why things do what they do, especially when it comes to brain science. And the imaging nowadays that we have is truly, light years ahead of where it was in 1980 when I graduated from chiropractic school. At that time, I think the MRI was still being developed, and the really hot thing there was CAT scans. Other than that, most surgeons were doing surgery based on x-rays and physical exams. So things have really come a long way since then. This particular sharing is about a particular kind of injury and also a particular kind of procedure that we do for it. It's not about just general chiropractic. It's not about general TBI. It's about this procedure and about what's involved in doing it. I call it a concomitant injury that has overlapping and severe long-term symptoms. It's concomitant to many cases who have been diagnosed with concussion, TBI, various levels of that. And I think that the reason we find it at the same time is the mechanisms that are involved in the actual trauma that creates the concussion. It doesn't have to involve a blow to the head, but it can, and it's very common for that. But in that force acting on the skull hard enough to cause the brain to have either mild or severe damage, in that force, there's also the possibility of changing the biomechanical relationships between the skull, the first bone, and the first bone and the rest of the spine. Does that make sense? Yeah. People get concussed in all kinds of different ways. And it's sometimes I think they actually walk around with mild TBI for years and years and never realize that that's what happened to them. They can have a wide variety of symptoms. This right here, I think, is from Mayo Clinic. I hope it's okay. I just try to, some screenshots and things. It's all right. Yeah, okay. Don't tell me. It was a funny thing. I had a heart thing going on, and the doctors here were like going, well, let's just see what happens and stuff, right? And there was a young man that I watched learn to ride a bicycle when he was just a little boy. But for the last 15 years, he's been a staff cardiologist at Mayo Clinic in Rochester. And so I called him and said, Paul, what do you think of this? And he said, send your EKG. And so I did. And sure enough, he said, come on out here, let's fix that. And so I asked him if it was okay if I told him to cut and paste off their website. He said it was all right. But are you familiar with these symptoms? Everybody in here is, right? I can go through them, but I put them up here because the similarities between this list of symptoms and what we would ask patients who came to see us in our offices years ago, before TBI became really recognized and popular. We simply referred to these cases as people who had just really bad problems for a really long time. And the similarity between these symptoms here and what we would look for in what's termed an upper cervical case, or a craniocervical case as it's called nowadays, are very similar, very, very similar. And some of them are very long lasting, and they're really life-changing experiences. I can go through this litany of cases and symptoms and things that people have had over the years. Some of them very dramatic, and some of them I actually have videos of, but not permission to show them to you. But the level of problem that can be created in people's lives associated with TBI and associated with these symptoms is monumental. Their families don't understand what's wrong with them. They have personality changes. They have strange symptoms that, there's just not a pill, powder, potion, or prescription that will sort it out. You know? There may be a mechanical issue in this. Okay, this is just your basic MRI. Right? Now, I thought about how to go about sort of making this real to you. Do you recognize anything in there?
Yes, I recognize the numbers.
There you go. All right, let's get oriented here just a minute. You see this right here? That's the angle of your jaw. You see that? So your teeth would be up here.
Okay.
All right.
Oh, now I get it.
This right here, that's that fatty knot on the back of your neck. Right? Okay. Right. This right up here, they call that your brainstem. And in that brainstem are, you were talking about the vagal nerve. Yeah, all those nuclei that are the source of that vagus nerve. That's where they are, right? And so blink your eyes. Yeah, that's where the nucleus is in there too, that blinks your eyes. When you look to the left and look to the right, up and down, the nerve that does that, it's there as well, right? Okay. Now, this right here, that's a cerebellum, okay? And that cerebellum, what it does is it creates a shortcut. If you had to think about, and you can ask anybody who's trying to recover from a stroke, they have to think about learning to walk again. Right. And it is a monumental task, or to learn to use that's because they have to use their cognitive part of their brain to formulate the whole process to have that movement occur. What your cerebellum did when you learned to walk and when you learned to do just stand upright, you learned to crawl and all of that, was because that cerebellum developed pathways and reflexive pathways within it that were basically shortcuts. So your brain could give the command, wiggle my fingers, and your cerebellum already had all that coordinated in it. And so basically it could just hit the app for wiggle my fingers and it ran, right? So the cerebellum is here. The rest of the brain is up here, okay? And the reason I took and pulled this one and not anything else is because this is the area that we deal with all day long. When you look at this, you're looking at it from the side. This right here, that's called the anterior tubercle of the atlas. And this is the posterior arch of the atlas. This right here is C2, or the axis. the odontoid process there, the body of it, the spinous process back here. And this long thing here, you know what that is? That's your spinal cord. Nature built this thing to be strong, to be resilient, to be it's almost indestructible. I mean, short of a hang-in or, all kinds of things that can occur. It is made with resilience. Now, why do you think nature would make it that way? Because you got to think when I say nature made it that way, all the ones that weren't that way were taken out of the gene pool very quickly. Okay?
It holds the core together. It's like the center.
Yeah. So what does your brain do? I know you question that sometimes, but what does your brain do? It's the center for so much. I used back before MRI, before CAT scans, before brain science, before all of that, medical physicians would take and say, well, they didn't believe chiropractic worked. And I said, of course chiropractic works. And they'd say, well, you can't prove that. I said, sure you could. You look at anybody that's been hung, it breaks their neck, it separates their spinal cord, their head is separated from their body, and now their body doesn't work. Death, right? Well, if you do that a little bit, along, you separate it a little bit, things go wrong. Well, I guess it can. Yeah, that's exactly right. But anyway, whenever you take a look at this area right here, when you talk about proprioceptive nerve endings, they're all over our body. They're all in the joints, all over us, our knees and our ankles, our toes. Everything has these proprioceptive nerve endings. Do you know what they do? That what they're for is like when you close your eyes or you're in the dark, you know where your hand is. Yeah, that's what they do, right? So you stand up and you got to get level with the horizon, and you use your eyes to do that, or your vestibular mechanisms. Yeah, that's what your brain's doing, right? It has all of these survival things that are associated with this area. And all of those survival mechanisms, I say survival because nature will sacrifice other things to preserve that. When you look at proprioceptive nerve endings, I don't know, I think there's an argument about the exact figure, but it's like half of them that are in your body because they're everywhere. But half of them that are in your body are between your skull and the first bone, and the first bone and the second bone in your neck. The reason is these survival skills of getting level with the horizon and having our vestibular mechanisms perpendicular to gravity are critical to us functioning upright on a day-to-day basis, right? So what happens is this. These structures in here, this right here is dural monitor. These are ligaments in dural monitor. And these ligaments all through this mechanism, all through this area, they allow your skull to act on a pivot. It's always easily movable and it's on a pivot. And what goes on then is you can easily have your brain and skull orient to the horizon and orient to gravity with your vestibular mechanisms. Nature can compensate up to 5 degrees for your crookedness of your head. And it will do that. But once it gets to a certain point, and once it's maintained that tilt for a period of time, it can't maintain it on its own. So what it does is nature begins to take and level your eyes by bending the rest of you. Right?
That's really good.
Yeah, it bends the rest of you. It's kind of like you can relate to how a child can only deal with so much of a frustrating situation before they explode, right? Well, nature takes and it says, I'll deal with this to a certain extent, but I'm going to have to make your shoulders crooked, and I'm going to have to pull one leg up a little bit, and I'm going to try to get this thing balanced so we can function. Right? Okay. In doing that, you can see compensatory aspects of this spine doing the things that it does, right? And it does a very good job of it. And most of the time, without any issue or problem, it just goes ahead and does it, all right? So remember I talked about the ligaments, right? Dural Monitor. I was trying to figure out how to explain this to you, but it's not as simple as a garden hose, but you can think about it like that. There is this, dura means tough and hard, right? And durable, right? And mater is matter or mother sometimes. But the dural monitor is a lining that basically takes and lines all of the osteology, all of your skull, the bones that make up your spinal column, and it lines the inside of that. It lines the inside of it and creates a space that, number one, is sealed from the rest of your system, except by very specific means. And it seals it so that it's hard to get it infected, it's hard to hurt it, it's hard to tear it, but you can do those things. It takes work, but you can do that. You can hurt it, right? So, when you start looking at this, there's Dural Monitor that basically lines this whole cavity here. You see your cerebellum, you see your brainstem right here, there's the pons right there. You can see that atlas bone right there. You can see that C2 right there, 3, 4, 5. And you can see all the spinous processes there, and all of a sudden, there used to be a ligament there, but now there's not. And there used to be a ligament right here, but now there's not. And you can see how this one is kind of expanded compared to the other version. That's because it's been kind of stretched and torn just a little. And on an MRI, whenever you start seeing it getting bright like that on a C2 weighted image, what that means is there's water that's imbibed into it. That's typically what we see with strains and things that are swollen and irritated and that sort of thing, which is not natural. And then this ligament right here has done the same thing. And you can take a picture of this right here, and you can go home and memorize all those things there if you like to. But basically, those are the hypothalamus important now to you. This is the kind of thing, these sorts of injuries, these sorts of things are the things that we see with patients who are struggling with this concomitant injury. And this injury involves when the skull gets moved hard enough, fast enough, awkward enough, that it actually loses that normal relationship that it typically has, and it doesn't bounce back like it typically would. Because as these things are, as well as they're made to throw them around and beat them around and do all sorts of things with them, and they're like a Timex watch, they keep ticking. And what happens then is whenever these kind of injuries occur, and it's hard enough, fast enough, and at an awkward enough angle, the bones can slide over like they naturally do, but they can go just a little too far. And then they just don't come back exactly as they should have. Does that make sense? Do you understand what I'm saying? Right? On an MRI, that's what some of that can look like. Once you start losing this level of ligaments in there, some of these ligaments are termed check ligaments. You know when you check something, you check the movement of something, it means it stops it. Well, when you stretch them and you rupture them enough, they don't check anymore. They don't check as well as they used to. Then all of that proprioceptive process up there simply begins a process of not being able to right itself. And that in turn creates a process that's commonly referred to as deafferentation. In other words, there's efferent and afferent nerve pathways. And this afferentation is where the brain can't sense everything that goes on. Right? It just can't sense everything that's happening as it naturally would do. So, in an upper cervical, when this upper cervical damage occurs, these are the sort of things that we look for. This particular aspect of it is one of the things that I find is most common. People can have TBI and not get injured in the upper neck. That can occur. It's kind of hard to see how it doesn't occur, but I guess it can occur. And in those cases, those people have other symptoms besides a headache. Right? They have a lot of other symptoms that they don't like a lot of headache. When this misalignment occurs, that is one of the cardinal things we look for, is a headache in some form. Okay? Patients will describe it at different levels, different, amounts of problem. Some people, it's a mild chronic headache. Some people, it's tension associated with what they do. Some people, it's associated emotionally with what they do. But still, we look for that particular symptom that seems to be pretty pandemic in this population that's been injured there like this, is headache. And it comes in lots of different forms. The other aspect of this that really stands out clinically is the description of the headache. It's a pressure sort of headache, and it's tight and it hurts. But there's also an aspect to it that is a knife-like pain that is typically in the upper neck or at the base of the skull. Notice how I said that, in the upper neck or the base of the skull, because the people, they will describe it like that. They'll describe it, it's in the base of my skull. And sometimes it actually can radiate up these occipital nerves. And then some people have been diagnosed with concussive syndrome, but they have a pain that is actually at the top of the neck. And it's very uncanny to me how common, this can be. And the poor folks, they'll, if their providers are not aware of the possibility of this cranial cervical problem, this thing goes very, very underdiagnosed. Right? It goes very underdiagnosed. All right, is that pretty good? Got that?
I have a question.
Oh, please. Yeah.
Okay, so you were saying earlier that there was movement, say from side to side, and you felt like if there was like a creaking noise or feeling like that, would that be like the C3 on the spine, or would it be those ligaments? It sounded like, like if it was moving back and forth like this, your head, from taking a hard hit, someone hit you, you didn't roll with the punch, like me.
Oh, yeah, when you talk about that, worst cases, IT people who take up boxing for fun. Worst thing, don't do that. Because number one, they're IT people, they're cross-country skiing, and these are not thoroughly, roustabouts on, frackers up on the North Slope. Nice people that, and then
now it feels better.
And then they take a right hook, you know.
I don't feel it as much now.
Yeah.
I don't feel it as much. You know, it's
Yeah.
I don't feel that like bone on bone. You know.
Yeah. The restriction can be pretty hard once that misalignment occurs. And I got to tell you, misalignment is problematic because when you analyze the X-ray, you may not see these huge angles. I'll show you some X-rays that have huge angles, and sometimes you don't see those. But when you analyze the movements that did occur, you realize that they are absolutely abnormal, that a normal spine does not move that way. When a normal spine tilts the head to the side, the atlas vertebrae rides up on that side, and the axis body and the spinous and the rest of the neck sort of go the other way, and it makes it a compensatory coupled kind of movement. These people, it's like their head tilted, their first bone went nowhere, and the rest of it's all kinked over to the side, and it's just that misalignment is misleading because sometimes it doesn't look like much. And then it was so funny. I have patients who are medical physicians, right? And so I'm showing the radiologist his X-rays, and explaining his X-rays to him. And as I went through the process of telling him what had happened, he went, "Holy smokes, are you serious?" I said, "You're a radiologist." He goes, "We see this all the time." I said, "Dude, I know." Years later, or whenever you're done with it, you know? And so it's an amazing thing, but doctors who know, like these chiropractors here, they'll tell you that it's odd. You can see that, right? And so that movement that you're talking about, most of the movement that occurs when you turn your head occurs between the first bone and the second bone in the neck. That's how it's designed to work. The rest of the bones in the neck are about 20% of the movement, right? So that's why you can fuse somebody's neck, and if their upper neck's okay, you can still get a lot of all movement out of it, right? When you tilt your head forward and backward, during that movement, most of that movement occurs between your skull and the first bone, under normal circumstances, that head nodding. And when you go like this, I mean, the rest of your spine participates in it. But when you change the alignment of it, even in those marginal ways, but it's absolutely abnormal, those movements begin having trouble. And so most people notice that, and when you have areas that don't move enough and other areas that have to overcompensate for that movement, that's the popping and grinding you hear.
But it only happens when it originally only happened side to side. But it's either is that I don't notice it as much, or I
Oh, you'll
kind of,
reprogram. Yeah.
maybe it's still there the same way,
Yeah.
but I just don't
Yeah,
feel
sure.
it or something.
Yeah. It's kind of like, I don't know, somebody told me if you get a cracked foundation and then over time it settles. You know, yeah. Right.
Question.
With the symptoms that you're talking about here, how often do you see these symptoms with patients who experience chronic traumatic encephalopathy?
You know, when you start delving into things that have affected meninges and linings and all of this, it does get to be just a milieu of these upper motor type symptoms. For years and years as chiropractors, my father was a chiropractor, my mother was a chiropractor, my aunt, my uncle, all of these, and great aunt back in the old days, whenever chiropractors treated people with all kinds of problems. We always wondered how certain cases responded to this or responded to that, because there's not a nerve that goes from here to those things. I'm going to explain to you how that happens. Not just meridian. See this right here? So these are the other symptoms that you would typically look at, that we would typically see with this. Drop attacks, where people just walk across a parking lot and they say, "My knee just gave out." Right. And that comes chronically. Dizziness. And it can be this transient sort of, how's that? which actually is not a bad clinical marker if you're trying to decide how somebody's doing as far as in care. But dizziness, loss of balance, numbness in the legs, and when I say legs, these things where people can actually get this numbness and tingling and that sort of thing bilaterally, you know? And after a while, if there's nothing in your lower back that shows you got a disc lesion or something like that, all of a sudden, you know, there's nothing wrong with it. Psychological, right? And so, no, we see this a lot. This paroxysmal vertigo is debilitating for a short time, but it recurs. And many of these people get diagnosed with things like veneers. You know, you got 3 or 4 symptoms that match, and they go, oh, you got veneers. This thing where people drop things, that's another thing I find commonly. Loss of color vision. You know, when you start hearing people describing stuff like that in an exam room, one of the first things I'm asking is, when was your last MRI? Right? Because these are lesions that could be there that are horrible conditions, but most of the time it's not. You know, the percentage chances of it being a brain tumor, of it being an aneurysm, of it being some sinister problem, that possibility is there, but it's not the, you know, you hear the hoof beats, you're thinking horses, not zebras, right? And so typically we're not seeing those, but we always are cautious about making sure. The numbness and tingling in the legs and the feet, and the vertigo on standing and walking, numbness and motor control in the upper extremities, that goes along with the dropping thing. And these are just very common things we see in addition to people complaining of spinal pain. All right, this is the vasculature to the brain. Most of it comes from where? It comes from the common carotid. One of the first branches of the common carotid before it just goes on up into the head is through the vertebral artery. And the vertebral artery goes through this real, and I want to ask, why was it made this way? I don't know. Wasn't around for the design. But the way this thing is made right here in this area leaves it vulnerable to mechanical issues associated with the upper neck, right? And we just got done with a study where Doppler studies were done on the carotid artery, and before treatment and then after treatment, and it was noticeably great. So we do know that. But this is, whenever this artery, it comes up through these little holes that are all in the side of the bone. It comes up around this C1, and it goes through what's called a transverse foramen, and it makes this dog-leg turn around this body of this lateral mass, and then it goes up into the skull from there. Wow, that's what I said. Why is that like that? And so it's tethered. It's essentially tethered at these levels. Right? Now there's give there for 999 people out of 1,000. There's a lot of give and stuff like that. There's always one. You remember that. Okay. And so this process right here means that it's somewhat vulnerable. Now, the common carotid will branch off into the vertebral artery and then the carotid artery. And the carotid artery is the main arterial supply to the base of the brain. But that vertebral artery goes across the front of the pons here. And remember we talked about all those nuclei? That's where tons of them are, is right there. And so that blood supply is critical when you get down to it. Okay, good? All right? Now here are the structures that are innervated by the nerves from C1, C2, and C3. Can you pinch the end of your finger? Do you know how you feel that? there's a nerve that goes there, right? You know, you pull on the hair in your head, you know, there's a nerve that goes there. That's how you know that. Well, the nerves from that upper neck, this is where they go. Okay, it goes to the inside of the lining of that dural monitor on the base of the cranium where the cerebellum sits. It goes to the tentorium cerebelli, which is a strip of dural monitor that separates the cerebellum from the brain. They also go to all the muscles in the upper neck. It also goes to the joints between the skull and the first bone, and the first bone and the second bone, and the second bone and the third bone. It goes to the skin on the back of the head. It takes it goes to the vertebral arteries themselves, which is, Dr. Ellingham, that's why people come in with neck pain associated with a tear, a vertebral artery tear. And many times all they have is neck pain. That's why. It's because that innervation is from the upper neck. Okay, and the ligaments that actually check and stabilize that upper neck, two large ones that are used all the time are called the alar and the transverse ligaments. They're also innervated by that, along with the trapezius muscle, which you know can reach up here directly. Right. Now, there's a fluid that's between the dural monitor and the pia monitor, which is the stuff that adheres to the brain itself. There's a space there, and that space is filled up by cerebral spinal fluid. Okay? It's a lot more than just a lubricant. It actually has what's called trophic functions, which is it nourishes and cleans and helps the brain. So if you have TBI and you have brain damage, how important do you think CSF flow is? It's a big deal. It's a very big deal, right? Not too much and not too little. You know when they do a lumbar puncture, you've heard of that, right? To see if there's an infection or other things that could be going on. You know when you do that, you have to keep people down because it can be so dramatic. It can give them migraines. It can make them dizzy. It can do all sorts of things because you remove just a little bit of that CSF. So it's kind of a delicate sort of balance of how much there is in there and how it flows. You got to understand, in 1980, I was not taught that it flows. That's a new development. But it actually, well, guidance textbook of medical physiology in 1979 didn't flow, it was just there. But nowadays, it's kind of like cranial bones. Right, where's the upper? Yeah. It's kind of like cranial bones, you know. If you fly over the border of the United States and you get outside of the United States, cranial bones move. But as soon as you cross the border into the United States, they don't move. Right? Just so you know, right? So when you go to like England and all of a sudden your bones move, that's what's going on. And the rest of the world accepts that, we don't. Now, I put this up here because it has more to do with homeostasis of the brain. In other words, keeping the brain well and well managed. Okay? Now, this is what it looks like whenever that flow is normal. Remember the face and the jaw, and there's the brain, and here's the spinal cord?
Yeah.
Right? Okay, this is a flow study. It's done on an upright MRI, and it flows with every heartbeat. It flushes, and you can see the flushing. When it's normal and the flushing is normal, you can see there's this nice area of fluids all through here that you can see where that CSF is, right? When you get problems in the upper neck, this is what it looks like. All of a sudden, the posterior part of that spinal cord is not covered. And actually, it can be right up against the dural monitor there. But you can see the front here, it almost looks bigger than the front in the other way, here, you know? Reason for that is that flow is going to occur. Nature's going to have it occur. And if there's an impedance in the way, it will try to go and make up for it otherwise. That means that you took a river that had two main streams and you put it all into one stream. What do you think happens to that stream bed where it all went? It starts to erode. It's got twice the volume. There'll be places where the bank starts to wash out because it's okay. This is cutting edge stuff, because this right here, this creates increased hydrostatic pressure in areas that are not designed for that.
That can't be good.
No, it's not. And this right here is some of why we have found in the past that certain types of cases responded miraculously, and we had no idea as to why. But nowadays we know from studies that have been done that this right here is a schematic of cerebral spinal inflow in a patient. And when you see any grade school will tell you green is good and red is bad, right? Okay, so you can see this as it's tracking the flow itself around the brain. This is abnormal, and you can see the peaks here of this flow. That's of the pressure, the peak in the pressure. That affects brain tissue. This right here is after we get them treated. Do you see the difference between this right here and that right there? That change in hydrostatic pressure apparently is a huge thing.
Question about that specifically: is the hydrostatic pressure at all connected to hypertension? Because the slide prior to, which is really amazing to think about, 32 gallons of fluid being pumped through
All around that area.
for every heartbeat, and so heartbeat connected to hypertension. Is that on the right side connected to hypertension as well?
Okay, this on the right side is connected to an atlas bone being out of place.
What?
Okay, now hang on a minute. There's an upper cervical doctor, and this is one of the few studies I know that's been published in a peer-reviewed journal, where he took, I think it was 52 cases of people with hypertension. And he was an Atlas doctor, and what he did is he adjusted these people. He took x-rays before and x-rays after so he could see if he corrected what it was he was trying to do, and then he kept track of their blood pressure, right? And it was part of the study, so somebody else measured the blood pressure. He did the work, and then they measured the blood pressure again over time. And it was very, very, very positive as far as the changes go, well beyond any sort of statistical, And so that's the only thing I know, right? But I do know that does exist. Okay, so there's things we need to know before we start treating people. Number one, we need to know if they got this problem, right? Because some people just have a concussion and they got other issues. But if they got this particular problem, how do we know that? And so, whenever you start looking at it, you need to look at genetic factors, you need to look at how the bones are made, you got to look at MRIs to see what kind of damage has actually been done and what you can expect as an outcome, right? And then, the symptomatic picture, and then there are some physical findings that are associated with this that I wanted to tell you about. That right there is the Atlas Orthogonal percussive adjusting instrument. Okay? And one is we want to see if they posturally, if this distortion has occurred, right, in their neck. And we look for that to see if their posture has reacted to that and if it's there. And so one of the first, and who does this happen to? God, I hear so many people. You know, I worked in South Carolina for years and years and years. I did a 25-year sentence in South Carolina. and it was nothing compared to Alaska. I have seen more interesting stuff and called Dr. Sweat, who developed the technique, and called him and said, "You won't believe what this looks like." And sent him screenshots of you know. Anyway, so there's lots and lots of people get affected by this. One of the first things we look for is to see if there is tenderness around the upper neck. And we do this digitally, we just palpate it. There's particular ways to palpate it. And I've always tell patients, I have very sharp fingers, I can make anything hurt. I need to know though, if if what you're feeling is outside of that, right? And so we do it, it's a very simple test, and that's how we do it. The postural distortions show up like this. We actually have a grid that we measure these things with, and this is with patients just laying down. They just lay down. That's about as complicated as it gets. We don't really shuffle their feet around. We don't really do much of anything. We just have them lay down, and then we just look and see how it is, right? Now, this doesn't take the place of the fact that some people are born with one leg longer than the other. Or they've had a broken leg, and you have to take all that into context, right? But that's the basic sign that we look for. And it's a common thing. The picture on the left is before we got them adjusted, and the picture on the right is after we adjusted. And so this is one of the things we look for. Now, I can tell you this, that when they don't get adjusted right, you put them in the pre, the post, they look exactly the same. I hate this test and I love this test. I hate it because it tells you how you did, right? But it's like a pop test, probably. I did. And so we got to get it so it's balanced again. And that's, you can see that on both of those. Now, this is the x-ray. A lot of doctors, don't care for this film because number one, it's hard to see everything. You ever look at those puzzles where it's like a 3D thing where you have to cross your eyes and look at it? That's kind of like that, right? But you can see how this neck here, when that head bends that way, that thing is not supposed to come up. It's supposed to go down. When that head bends that way like that, that neck is supposed to bow this way. And none of that's doing that. And then after we get it adjusted, we can take and remeasure with the same landmark and figure out again if we did what we were supposed to do. Then you can see on this one right here, some people do have the head on the right sometimes, and sometimes it's on the left. Okay? But this right here is is the misalignment as it typically shows up, and that's how it will typically look whenever you take and correct it. The x-rays, they're anywhere from 15 to 20 minutes apart. Okay, so the thing I like about the procedure, number one, we can see there's something objective there for us to try to take care of. And the other thing is there's something objective I can check it with to see if I did do that like I was supposed to. This right here is a picture of the neck. This is a young man after he had a car accident, and you can see this space right here and this space right here. See the difference in that? That's what it's supposed to look like. And again, with this kind of rotation and that amount of displacement, this is actually my youngest daughter's boyfriend, and he had an accident. She said, "You gotta go see Dad. Come on, you gotta go see Dad right now." So this thing had been that way just for a few hours. And so we were able to take and get it adjusted and have it replace itself before all the old scarring or any. So it basically, we hope that it healed up that way, and he hasn't had trouble with it since. So we're hopeful that's good. And when it's a common thing to see, you can see this space here and that space there. There's the Atlas vertebrae. And then you can see how it equalizes. And that's what you want to see. You can see how the neck is all bent over this way, and then after we get it done, it's right back in the middle. Now, this doesn't mean that everybody is born with everything equal. I mean, seriously, people have different. We're done?
No, 10 minutes.
I got 10 minutes?
Yeah. Are you done? We have questions.
Okay.
I was giving you a couple extra minutes. You were on a roll.
No, it's fine. This is me. That's Dr. Connie Jers. That's Rizaldi Ortiz. and that's John Pairmore. And John Pairmore and I formed Pairmore and Young years ago, and then these two doctors came to work with us, and both of them are great fishermen, and they're also great chiropractors. Okay, I'm up for any questions you have.